So as you are crafting your cognitive perceptual interventions, it's important to understand what approach or model that you're using, because you won't necessarily be tested on what is the definition of this particular approach or this particular model, but you'll need to understand what that approach or that model addresses, which will then help you correctly identify what intervention you're going to use. And this will be important for when you take your exam to be able to identify the rationale behind what the intervention is in the question. So there are a pretty hefty number of models and guiding approaches for OT interventions for cognitive perceptual dysfunction. So this first remedial restorative transfer of training approach, this one focuses on restoration of components to increase skill. So it really is deficit specific. So it's, focusing on memory and then restoring the components of memory to increase skill. And it targets the cause of symptoms, and it emphasizes performance components. So it assumes that improvements in the performance components will result in increased skill. It also assumes that the cerebral cortex is malleable and can be reorganized. So think neuroplasticity here. And this approach really utilizes tabletop and computer activities. For example, memory drills, block designs, parquetry as treatment modalities. And then your next approach, compensatory, adaptive, functional approach, cognitive rehabilitation, retraining. This one involves repetitive practice of functional tasks. So doing the functional task again and again and again to develop the appropriate pattern. And it also emphasizes modification. So for example, modifying clothing closures by using Velcro to replace buttons and or zippers for those who might have a motor apraxia. The activity choice is driven by tasks that the person needs or wants to perform, and it emphasizes intact skill training, and it treats the symptoms, not the cause. It also utilizes techniques of environmental adaptation. So for example, placing a list of morning care activities on a bathroom mirror for those with memory loss or sequencing issues, and compensatory strategies such as taping lectures in school for those with poor sustained attention. This approach also uses compensatory cognitive strategies that require some level of awareness of deficits. So if we have somebody who has poor self-awareness, this is not the technique that you would use with that client, because they need to understand what their deficits are or recognize that they have deficits. Environment modifications may be caregiver driven, and the treatment again is task specific. It utilizes functional tasks, for example, basic ADLs, IADLs, work and leisure tasks that the individual desires or is required to perform at discharge as the basis of their treatment. Then your information processing approach. This provides information on how the individual approaches the task. It investigates how performance changes with cueing. Standardized cues are given to determine their effect on performance. For example, try rereading the recipe or try speaking the steps out loud. Cues or feedback are utilized to draw attention to the relevant features of the task. And we use investigative questions with this approach. So for example, why do you think it took so long to get dressed? Or do you know why I had to help you balance the checkbook? Because we're using these questions and cues to provide insight to the underlying deficits. Your dynamic interactional approach or model, this emphasizes the transfer of information from one situation to the next. Is your client able to generalize? It utilizes varying treatment environments, so generalizing from the kitchen to the somebody else's kitchen, or from the bedroom to the bathroom. The practice of targeted strategy with various tasks and situations. So it's multi-contextual. It emphasizes metacognitive skills, so it requires self-awareness of strengths and deficits as the basis of learning and generalization of learning. The transfer of learning must be taught from one situation to the next and does not occur automatically. So the therapist is actively engaged in this process. The transfer of learning occurs through a graded series of tasks that decrease in similarity. For example, training scanning strategies for a person with a visual neglect to find items in a refrigerator to a less similar task such as scanning to cross the street. The person's processing abilities and self-monitoring techniques are used to facilitate learning for different tasks or environments. The therapist utilizes awareness questioning such as, how do you know this is right, to help the individual detect errors, estimate task difficulty, and be able to predict outcomes. So there's that dynamic between the therapist and the client. The quadraphonic approach, is based on remediation. It's based on information processing theory and teaching and learning theory, which I know you are all familiar with. The micro perspective includes evaluation of management of performance component subskills such as attention, memory, motor planning, postural control, and problem solving. The macro perspective evaluation includes the use of narratives, interview, real-life occupations such as shopping, cooking, and other IADLs. It does make use of several other theories, so the information processing theory, teaching and learning, neurodevelopmental evaluation, and biomechanical evaluation. So it uses all of the skills that you have learned thus far to really be able to create an intervention plan for this client. And the neurofunctional approach is based on learning theory. It's specifically used for individuals with acquired brain injury or acquired neurological impairments such as TBI or CVA. It focuses on retraining real-world skills rather than the cognitive perceptual process. It utilizes an overall adaptive approach, but incorporates some remediation components. The treatment is focused on training specific functional skills in true contexts. Your task-oriented approach. This one helps clients adjust to their role and to limitations in performing tasks. It creates an environment that uses the common challenges of everyday life. This particular approach, you practice functional tasks or close simulations to find effective and efficient strategies for performance. So a lot of these approaches have some similarities and some crossovers to them with a little bit of difference. And then finally, the cognitive orientation to daily occupational performance is used to the co-op. It's client-centered problem solving, and it is performance-based, using performance-based interventions. So those would be some of the approaches that you would use to crafting your interventions. Some general intervention strategies for specific deficits. So if we're thinking about the remedial restorative transfer of training approach, these would be if we're using specific interventions for impaired alertness, aphasia, apraxia, body neglect, memory loss, perseveration, sequencing, spatial neglect, and spatial relations. So some specific ways that you might address these deficits are for impaired arousal or alertness. You would need to increase the environmental stimuli. This would be, for example, let's say the person who is Ranchos Los Amigos, like level 3, where they're in and out of awareness and alertness. This is the person that you need to get out of bed. So when you walk into the room and they don't open their eyes and you provide sensory stimuli such as a sternal rub or nail bed pressure, this is the person that you need to move to help with their alertness and their arousal. For your clients with aphasia, so some sort of communication deficit, you might want to decrease the external auditory stimuli so that they can focus in on what it is that you're actually asking. You might want to give them increased response times. You might use visual cues and gestures, using clear, concise sentences, and this is the client that you might use AAC devices with. So and please be sure to understand that a communication impairment should not be confused with a cognitive impairment. So really understanding what the difference between those two are. So for your motor apraxias, ideomotor, you want to utilize general verbal cues as opposed to specific cues. If I say, pick up the notepad on the table and bring it over to the desk, that is very specific, versus using a more general cue such as pick up the book. Much more clear and concise. And decrease manipulation demands, because it is a motor apraxia. The planning of that motor task with a manipulative might make the activity more challenging. And because of that, you might then use that hand-over-hand tactile kinesthetic input, and also using visual cues. So if I ask somebody to scoot to the edge of the bed, I might use that concise verbal cue, scoot, as well as bring my hands forward to help layer on the cues for understanding. Or your ideational apraxia, kind of similar approach, providing step-by-step instructions, again using hand-over-hand guiding techniques, and providing opportunities for motor planning and motor execution. Your body neglect, providing bilateral activities so that they have to incorporate their more impaired side. You might use, again, that hand-over-hand technique by guiding the affected side through the activity and perhaps increasing the sensory stimulation to that affected side, to tapping or rubbing or some way to increase awareness. Memory loss, you might use a rehearsal strategy. You might use chunking of information. So for example, for recalling a phone number, the person could chunk the digits into 3 groups. The first, the area code, and then the next 3, and then the last 4 to help with that memory retention. Utilizing memory aids, or utilizing temporal tags that focus on when the event to be remembered occurred. So the cue of yesterday at breakfast would be that temporal context to help with recall. Perseveration. This does require a level of self-awareness, so bringing the perseverative behaviors to the conscious level to train the client to inhibit that behavior. This perseveration could be both motor or verbal output. You could also redirect their attention or engage the individual in a task that requires repetitive action to break the perseveration of the motor task. Sequencing and organization, you might use external cues such as written directions and daily planners, and you might grade the tasks that are increasingly complex in terms of numbers of steps required. Spatial neglect. Some strategies or interventions provide graded scanning activities, so increasing the complexity of scanning towards the spatially neglected environment. Grade activities from simple to complex. So if you're walking in a hallway, and their inattention or neglect is towards the left environment, you might have one person walking down the hallway towards them that they need to acknowledge and then avoid. And then to increase the complexity of that, you might go into a more high density environment, such as the gym or a coffee shop. You could use anchoring techniques to compensate for this spatial neglect. So using a red strip of tape placed on the left side of a sink to draw attention to that hemifield. Utilizing manipulative tasks in conjunction with the scanning tasks. So they need to look towards that left environment, let's say, while engaging in a task. And you might use external cues, such as colored markers or written directions, to acknowledge that spatial awareness. And then spatial relations dysfunction, you might utilize activities that challenge the underlying spatial skills. So for your client who is unable to identify front from back, left from right, up from down, you might try orienting the clothing to the body during dressing, using wrapping a gift or making a bed to identify left, right, up, down, front, back. And then pairing that with cues to identify dress your left arm first or place the items in the lower right cabinet so that you're pairing a motor activity with the direction or, the task activity or the spatial relation that they need to identify. So I hope those little approaches were helpful, and then having some more concrete interventions that directly address the deficits were helpful. And don't hesitate to reach out.